Hi, everybody. Welcome to another episode of the GenomeCare Podcast. Today, I have a wonderful guest, Sarah Long. Sarah is a very experienced genetic counsellor who works in the public hospital system in Western Australia. She's also done a lot of work in the research space and has had teaching roles as well. And I've invited Sarah along today to talk to you about genomic sequencing, particularly in the prenatal context. But Sarah, what we might start with is just if you could tell us a little bit about your background and how you came to work in the area of prenatal genomics.
Yes, absolutely, Alison. So I became a genetic counsellor in 2008, which was long before next generation sequencing, which is what we use, allowed whole exome or whole genome clinical application. And I'll take some time and explain what a whole exome and what a whole genome is in a little bit. So I was actually working clinically in familial cancer when prenatal genomics started being introduced into the prenatal care at the genetic services I work at. And then once I started as a genetic counsellor with PREGEN project, which was looking at genomic testing in pregnancy when there were changes on ultrasound of the baby, I became really familiar with it. And my PhD, which I finished last year, actually hypothesized the use of this technology in 2014 through non-invasive means. I moved from familial cancer back into adult and reproductive genetics around October 2024 and started working clinically with patients undergoing prenatal genomic testing. And just to clarify, the PREGEN implementation study was basically looking at scalability and implementation of prenatal genomic testing. And it allowed people who could not previously access prenatal genomic testing to actually get that technology if there was a change in the baby detected on ultrasound. And it was quite successful. There was a diagnostic rate of about 35% with prenatal exome and genome sequencing, which is similar to other research studies.
Yeah, that's quite amazing. And I guess it shows the benefits of trialing and applying that technology.
Absolutely.
So can you tell us a bit more about genome sequencing technologies in the prenatal context? What technologies are used? How do they work? And what do people need to know in order to understand what's happening in this area?
Okay. So at the moment, if there's something found with the baby on ultrasound, the mother might have a chorionic villus sample, which is called a CVS, or an amniocentesis. Even these procedures have been around for decades. They're not new because of genomic testing. It's just that the sample that we take from these procedures can be used for genomic testing. So chorionic villus sampling, or CVS, uses a needle that goes usually through the abdomen to sample a bit of the trophoblast, which makes up the placenta. And amniocentesis uses the needle going through the abdomen to take some of the amniotic fluid around the baby, which has the baby's cells and DNA in it. Now, we typically take the parent's blood or saliva at the same time because it's best practice to do prenatal genomic testing in trios, where we test both parents and the baby at the same time to compare the findings. And this helps us know whether a genetic change or a variant is likely to be a problem, which we call pathogenic, or benign. It's just a normal variation found in the human population. It can, however, also mean we find things in the parents we weren't expecting. When one or both parents aren't available or they're not biological parents of the child, we do a single fetal genomic test, but it is harder to interpret. So once the parents and fetal samples have been collected, they undergo whole exome or whole genome sequencing. And in the PREGEN study, we had an average turnaround time of about 21 days. The major difference is that exome sequencing covers the coding regions of DNA, which is about 1 to 2% of the genome, and about 85% of variants will be in that exome. Whole genome covers the non-coding areas as well. However, surprisingly, we haven't seen much of a huge difference in detection rates between whole exome and whole genome sequencing. So the DNA is extracted from the samples in a laboratory, and the DNA is broken into many small pieces. And then special machines called sequencing platforms read the order of the chemical building blocks in these pieces of DNA. Computers then assemble these pieces together and compare the sequence to a reference human genome. And this allows scientists and doctors to identify differences or changes in genes that may explain a medical condition, increase disease risk, or affect how someone responds to treatments. So by analysing these genetic differences, genomic sequencing can help diagnose genetic conditions, guide medical care, and provide information for families about inherited conditions, including risk to future pregnancies. And sometimes this result may need to be discussed in an urgent multidisciplinary team meeting prior to giving it to the patients, depending on what was found. So there's a few different steps. And I guess the last one is, and not the least, is giving it to the clinical team to communicate to the patient and do the ongoing counselling about the implications.
So there's a lot, it's a comprehensive process, and there's a lot to understand about the process. In what situations are prenatal exome versus prenatal genome technologies used when you're testing a CVS or an amnio sample? How is a decision made about doing one or the other approach?
Yeah, so it depends on a few different ways of how ladies or birthing parents might actually come in to the situation. In PREGEN, we had very few people who at the first trimester, so at about 12 weeks, they had the scan to check for early fetal development and also screening for common chromosome conditions like Down syndrome, trisomy 18 and trisomy 13. And if something is detected, then CVS or amniocentesis might be offered. And they might do microarray or a karyotype, which is a picture of the chromosomes. And they usually do a quick test called QF-PCR, which gives you those chromosome disorders, a quick result in 2 days. Now, initially, PREGEN was asking for a normal microarray before we started doing whole exome sequencing. But then we realized we were pushing out results by an extra 10 days. And of course, in a pregnancy, those 10 days can be really important. So we started running them concurrently, microarray and whole exome sequencing. And this is really important because while I'm talking about the first trimester or 12-week scan, most of the patients in PREGEN had the changes found on ultrasound at their 20-week anatomy scan. And when the doctors consulted with the geneticist, it was if it was thought the changes seen on ultrasound could be due to a Mendelian disorder, so a single gene that you can pick up through whole exome or genome, then we process to genomic testing. When whole genome sequencing becomes the norm, because at the moment whole exome is a bit more accessible because of the price, and whole genome is being set up at the moment, although it is set up in a few labs that participated in PREGEN, we won't actually need a microarray as well because whole genome sequencing can detect copy number variants like microarray. So I guess at the moment, genomic testing is only used when we can see differences in the structural development of the fetus and not as a general screening tool.
Okay. For patients and practitioners less familiar with genomics, how would someone know what type of genomic test that they're getting if they're having a diagnostic test? So they've had a CVS or an amnio sample taken. Who decides what test is being performed and how do they know?
So that's the clinical geneticists and genetic counsellors who will see the patient. They're the one who usually order the test. Sometimes other specialists do, but we've been working on getting a Medicare item number for this test. And it'll mean that geneticists can order it and fetal medicine specialists in consultation with a geneticist. So it'll basically be on a case-by-case basis based on what the phenotype or the clinical picture of the baby looks like. It also depends on resources. So at the moment, whole exome sequencing, I think, is around $3,000, whereas whole genome is coming down quickly, but I think it's still around $7,000 in some places. And the detection rate doesn't differ hugely. So depending on the hospital that's providing it, it might just have to go with the cheapest test, which still has excellent coverage rather than a whole genome.
So as I understand it, whole genome is more for, it's possible in some circumstances, but it's more for the future when the costs come down because there's more experience dealing with the technology. So from a patient's perspective, the process is there are findings on ultrasound, sometimes at the 12-week scan, but more often at the 20-week scan. And then a patient would be referred to a maternal fetal medicine specialist for a genetic service, and genomic sequencing would potentially be offered depending on what the findings are on the ultrasound.
Absolutely. So we know that there are things that are not caused by single gene disorders, and that's things like amniotic bands, when the amnion or the sac around the baby gets these little strings coming off it, and it can wrap around the baby's limbs and cause problems, or the baby might even swallow it, which can cause very big problems. And so you can see that things are changed on ultrasound, but we wouldn't offer whole genome testing or whole exome sequencing in that sort of situation because it's not a single gene disorder. So it does take a fetal medicine specialist and a genetic counsellor, a genetic clinical geneticist to really come in and say, okay, that looks like a single gene disorder.
Yeah. Okay. So a specialist assesses what's being seen on the scan, and based on their deep expertise from a very long time of working in the area, they would then make a assessment about whether genomic sequencing is appropriate on this.
Yeah. And then I think the most important thing is that it is offered to the patient, but it's not something that should be pushed onto patients, because there are patients who have opted not to know and just enjoy their pregnancy, and they'll deal with whatever's going on with their baby once the baby's born. And there's other parents who are very information seeking, and for them, this test has been really helpful. And of course, in the PREGEN study, we saw more of these information seeking parents because they wanted to participate in the study. So we didn't come across the people who did turn down genomic testing, although I think that would be a really interesting study to do, to look at the people who declined this kind of test and their reasons for it.
So thinking about the people who do get offered this testing in pregnancy, and I know this is your area of expertise, understanding patient experiences, what is that experience like for people who are offered that testing? We can probably break it up into what it's like to be offered the test and then what it's like to receive the results.
Yeah. When I first started with PREGEN, I wasn't working clinically in prenatal diagnosis. So I was interviewing patients about their experience and analysing the data. Now I'm working in adult and reproductive genetics. I'm working clinically and presenting that as an option to patients and counselling them through it. So once they've had changes found on ultrasound, that does throw them into a bit of internal chaos. And it's a very quick timeline because you have to make a decision. You might be offered amniocentesis at the same time as an ultrasound. It's a very stressful situation. So what we did was we did 2 interviews in PREGEN. We did one at what we called time point 1, which was after they had an amniocentesis or CBS, but before they received their result. And we did one at time point 2, which was 6 months after they received the results. So the wait for results was commonly mentioned as raising anxiety during pregnancy from the majority of people whose transcripts we have analysed. So the people, like I said, who participated in PREGEN were very much information seekers. So that was another major theme to come out. Very motivated to undergo genomic testing to find out more about their unborn child. And then after results were returned, many people still reflected on the anxious wait they had during pregnancy. So with the time point 2 interviews, we transcribed 57 transcripts from 54 families, 54 birthing parents and 3 partners. And they were split into 4 cohorts, and the cohorts weren't equal. We actually started off with 10 from each cohort, and then we kept going until we couldn't find any more content categories. So the 4 cohorts were nothing found on genomic testing, which we called negative, negative and continued the pregnancy, negative and ended the pregnancy, a positive result and continued the pregnancy, and a positive result and ended the pregnancy. And one constant over all cohorts was that they valued genetic counselling follow-up regardless of their result. So even when nothing was found, a short phone call just telling them that wasn't satisfactory for a lot of parents. They wanted to ask further questions or have the report explained to them. Even just a sort of follow-up just to say, do you have any questions? How are you feeling about the pregnancy? Would have gone a long way with a lot of these parents, I think. For people who received a result showing that there was a pathogenic, a disease-causing genetic variant in their child, there was a lot of shock, even though they had been counselled that this was an outcome. We noticed this was especially prevalent in families where an autosomal dominant condition that was inherited from one parent was identified and the parent hadn't known about the condition previously. So, as well as shock, this caused other reactions. So, there was one mother who was diagnosed with a condition causing learning delays and behavioural issues. And she said, and her child was also diagnosed, her fetus. And she said this felt like an explanation why she struggled at school. And she wasn't worried about her child being affected because she had managed. And around the same time, they tested her other child and they were also affected and they were doing quite well. So it had a variable clinical picture. She had it, she was quite comfortable, and it gave her a reason for why she struggled in school. So that was quite a positive outcome for her. However, another participant, her partner was identified as having a mild version of the same brain developmental condition their unborn child had. So for her, this actually increased anxiety that something would happen to her partner, as well as being concerned for her child. So there was quite a few people who did get a diagnosis because they had the same thing as their child. And that was really interesting to look at. Another really interesting point was both participants with positive and negative results found the results a mixture of reassuring and increasing uncertainty. And by this, I meant some people found results reassuring in that they felt they could deal with a genetic condition in their child. So lots of people did continue pregnancies when a genetic condition was found. They felt they could manage the genetic condition and their child would have a great quality of life. And sometimes that was quite reassuring. They knew what they were dealing with and they had the information to go forward. And people who received a negative result and decided that the ultrasound images were not bad enough to make a decision to end the pregnancy decided to continue on. And they found the results quite reassuring as well, even though they know that genomic testing can't exclude every single genetic disorder because there are genes we don't know about yet. It was an attitude of we've got all the major disorders wiped out and the ultrasound doesn't look that bad, so we feel reassured. But around an equal number of people found they experienced uncertainty about the result. So with positive results, there are a few that were returned and the condition was so rare, there was very little written about it for the patients to understand. And there was little to no answers on what would a child with this condition be like and how their life would be like. So that was really upsetting for people. And sometimes where there was a negative result, but the ultrasound looked really serious, then the parents were faced with a lot of uncertainty. Is the ultrasound what we should base our decision on if we haven't found anything on the molecular testing? That was quite interesting. Another thing is that we looked at the quality of life at the first time point 1 interviews and at time point 2 interviews. And it showed at time point 1, when people have received the diagnosis of a fetal anomaly and are waiting for results, quality of life is lower than the general population. But 6 months later, it's pretty much back to normal. And that's from both groups, the groups who had positive and negative and who ended and continued the pregnancy. So really, we show that it's the fetal anomaly that's possibly causing the quality of life decrease at the start. But there's no lasting harm from genomic testing. And we also looked at decisional regret about having the test, and that was really minimal as well. I think the mean score for decisional regret from 0 to 5, 0 being no regret and 5 being strong regret, I think the median was about 0. in our findings. So there was almost no regret about having the test.
Wow, there's so much in that. First of all, I just want to say for a study doing interviews, 57 interviews from 54 pregnancy scenarios is a huge data set. Well done on capturing all that data. That's amazing.
We actually did about 300 interviews and we collected data. We interviewed, except for the last 6 months of the PREGEN study, we interviewed everyone who participated. We only stopped in the last 6 months because PREGEN ended in December 2025 and we didn't have anybody to do the T2 interviews 6 months after June 2025. So that's why we stopped the interviews. But we've got an amazing data set.
Yeah, I mean, that is phenomenal. And it's no mean feat to analyze that much data, speaking from experience. But before I ask more questions about people's experience, I just want to rewind a little bit and get you to go through, for listeners who are less familiar with genomic testing, particularly in the prenatal space, what a negative result means. So if you've got a clinical situation where you've got a patient with some findings on ultrasound, and so they've met criteria to be offered genomic sequencing, whether it's exome or genome, and they have that testing and a negative result comes back. What does a negative result actually mean in that context?
So I'm not a big fan of the use of the word negative, although it is the terminology we've been using in the PREGEN study. I think uninformative is a better term because we're not saying there's nothing found, your baby doesn't have a genetic condition. We're saying nothing was found. This decreases the likelihood of a serious genetic condition, but it's not a 0% risk. And that's simply because there are genes we don't know about. And like any technology, there are limitations. There are areas of the exome and genome that are really difficult to sequence. Things like pseudogenes, there are still certain things that can only be picked up by other different technologies as well.
Yeah, I totally agree with you about the terminology. I think uninformative is much, much more used. And in screening, which is the area that I'm really familiar with, we often use low chance, acknowledging that there is still a possibility. And I think that it makes a lot of sense to use a term like uninformative because you've got a situation where there are some findings on ultrasound. There could be things going on that the genomic sequencing's not picking up.
We did have a few diagnoses after birth of children that had genomic sequencing in pregnancy. And one of them, I won't go into it because it might identify the patient, but the mechanism of the genetic condition was such it wasn't picked up on microarray or whole exome sequencing. And that was a diagnosis that they picked up using a different methodology after birth when they looked at the baby and found, hey, this baby has X, Y, and Z. Let's check for this certain genetic condition. So they really targeted it. And there were a few children born that have conditions that don't have identified genes for. So they've got a clinical diagnosis of a condition, but there's no single gene known to cause the condition.
Those are great examples of why across genomics, when we think about a result that didn't show up anything, we are always quite cautious about our language, aren't we? Because
Absolutely.
there's never really a 0% chance because there are so many different biological mechanisms.
I find it really difficult to walk that line in between giving hope without being overly reassuring, because if you do whole exome or whole genome sequencing and you don't find anything, the outcome for the babies is likely to be pretty good compared to if you do find something. And we kept data 6 months after all the babies got or all the parents got their results. We kept data on the outcomes of the babies and we showed a lot more healthy live births in the negative group than in the positive group, the uninformative group, I should say, than the positive group. So it is reassuring if you do get a negative result, but it's important just to let them know it doesn't exclude everything.
Yeah. And so I guess just unpacking that a little bit more. So I guess in that situation, what we're asking people to understand is that they can draw reassurance from a result that hasn't got anything to report, an uninformative result, but also just hold on to a degree of awareness that not absolutely everything has been excluded. How do you find people navigate holding those two pieces of information that are somewhat contradictory together?
I think the bread and butter of genetic counselling is helping clients deal with uncertainty. It always comes back to that in familial cancer, in prenatal, in adult genetics. There are very few genetic conditions where you say, you have X, you are going to be affected with X, and we know that you're going to be affected at this age. I can't think of any genetic conditions other than childhood disease where we can say that to an adult. And even if we can say that to a person in pregnancy where they have a known diagnosis, we still can't tell them exactly what their child's life is going to look like. And I think in all areas of genetic counselling, that is a critical skill to be able to work with people dealing with uncertainty and help them adapt to that uncertainty and make it part of their narrative so they can live with that uncertainty in a comfortable manner. And it's very tricky to do. And I've actually just about to do some more reading up on that for a case that I've got coming up. So don't ask me too much about how to do it because it's something I'm currently trying to brush up my skills on, even though we tend to do it every day in some manner or another.
I love that because I was about to ask you exactly that question. But yeah, look, I think sitting with uncertainty, it's one of the hardest things for us to do as human beings. Our brains
Absolutely.
do not like uncertainty. We are not wired that way, and uncertainty is threatening. I just recorded another episode on Wednesday with Peter Shakes, and she talks about that in terms of her research and the people who took part in her research who had the experience of going through prenatal diagnosis. And uncertainty is one of the most common themes in prenatal diagnosis. And I think sometimes even just, whether we could probably have a whole separate episode on uncertainty, so we'll mostly park this, but I think even just naming it for people and acknowledging that they are in that space and acknowledging that we're asking them to hold, in terms of an uninformative result, to hold some hope because it is reassuring, but also to hold that awareness that we can't test for everything. So just knowing that we see that and that they're not alone in that, and that other people going through prenatal testing also deal with that challenge. I think even that in its own right is helpful for people to have that, know that there's that awareness and that empathy for that aspect of what they're going through.
Yeah, I think you've put it perfectly. Just naming it and validating it can be really helpful. A lot of pregnancy is so unknown anyway, especially for first time parents. You go in, the doctor says you do all these tests. Half the time you don't question or actually understand what you're doing. You go to your scans, you expect to see your baby for the first time and hear a heartbeat. You go to your 20-week scan and you're getting really excited by this time. The last thing you're expecting is to see something different on ultrasound that could have a serious impact for the baby. Really, even before people get a diagnosis of something different on the ultrasound, there's a lot of unknown just in pregnancy anyway. And I think that is compounded when you get a diagnosis with the baby.
Absolutely. And I'm sure you've seen this in your clinical practice. I think it's one of the biggest things that strikes me about working with people in pregnancy is that often pregnancy is the first time in a person's life where they've really encountered anything very complicated. And I think often, even though people can be as prepared as possible to embark on a pregnancy, it's not until they actually step into the journey that they realize the amount of uncertainty they've actually taken on in terms of stepping onto that path to creating their own family. And so people have thought about the prospect of having children, but they haven't thought about the prospect of the uncertainty that they need to hold while they're doing that.
I think that's why I find prenatal genetics the most rewarding area to work in, because there's a lot of fear and uncertainty. And the way I like to look at it is I'm making the worst time in someone's life a little bit less crap for them. And I
Yeah.
did censor what I usually say. But I figure if I can just make this a tiny bit easier to understand, if I can provide a bit more support while they go through this, and if they get through this and they can make it part of their narrative and adapt and live with it in a healthy manner, then that's the best thing I can possibly do with my life.
That's amazing. I want to touch on that again in a moment. Before I do that, I just want to walk people through what it means to get a result where there is a finding. And I just wondered, for those people who might be listening who don't have the experience of working in the genomic space, whether you could explain what happens when the genomic sequencing is done and something is identified that might be of clinical significance. What happens from there on?
Okay, so in the prenatal context, we would usually make an appointment. Some people give results by phone. We always contract at the first appointment before we do the test how we're going to give the result. And usually we encourage that if they do want it by phone, we email them beforehand to set a time so they're not getting a result in a work environment or at a bad time. So it's all planned very carefully about how to give a result in the first place to cause minimal harm to the patient if it is a positive result or a really serious diagnosis. We prefer doing it face to face because that way the clients have an hour or patients have an hour and they can ask questions. Even if it's negative, they might not stay the whole hour, but they've got that time if they want it. When it's positive, it's often a combination of a bit of shock, sometimes a bit of relief that they've got an answer, but it can also be quite devastating depending on the diagnosis. So it really depends on the diagnosis. In PREGEN, we had a few genetic diagnoses which explained the fetal ultrasound findings, but they actually weren't very severe. They looked bad on ultrasound, but the actual prognosis or the condition is something you can easily live with and have a good quality of life. And the features on ultrasound could resolve after birth. So for those people, they had an answer. It explained what they saw in ultrasound, and they were quite happy to have a child with the condition because it didn't bother them. So for them, getting a result was a really good thing. Whereas other parents, we've unfortunately had diagnoses that are lethal, and this is really devastating for parents. And I think almost even harder is when a diagnosis isn't lethal, but the outcome is really hard on the parents and the child. And then they have to make a decision about whether to continue or end the pregnancy. I think in a way, this is even harder than a lethal diagnosis because a lethal diagnosis, if you wanted to, you could have palliative care and not have to make a decision about the pregnancy. But when it's not a lethal diagnosis, then you've really got to make a very personal, very difficult decision about whether you can parent a child who might be really severely affected with a genetic condition or have a limited lifespan.
Yeah, and there's a huge emotional and cognitive load that comes with that burden on decision making.
And that's really where genetic counsellors shine. We do all our appointments with people who have changes on ultrasounds with a clinical geneticist and a genetic counsellor. So we always have a genetic counsellor involved. And we do all the follow-up in WA along with midwives and bereavement midwives if they do end the pregnancy. We've got really good support systems over here. And I tend to follow my patients up for about 6 weeks. And if they end the pregnancy, after about 6 weeks, we bring them in to talk about how they're doing, recurrence risks in future pregnancies, and generally just make sure they understood what has happened and the results and everything.
So I want to talk more about the support, but just going back to the technicalities of the result where there are findings, can you talk a little bit about the amount of clinical evidence that exists in assessing the significance of a finding on genomic sequencing and how that works? Because people might see some of that referred to on laboratory reports.
Absolutely. So I guess you're hinting at variants of uncertain significance, which is what I like to blame for my wine consumption. I actually don't get that many booze, so I probably shouldn't be drinking as much wine, but that's what I blame it on. Now, for those of you who don't know what a VU is, a variant of uncertain significance is what it sounds like. It's basically if you think of DNA, the rungs on a DNA ladder, like being letters of the alphabet, and a chunk of DNA spelling out an instruction, that's the gene. And when we find a spelling mistake and we can't read that gene anymore, we know that variant causes a problem and it's pathogenic or disease causing. So we call it a pathogenic or likely pathogenic variant. And then on the other hand, you can have a little spelling change, but you can read the gene just fine. And that's just because people are unique and they do have little changes that don't affect how the genes work. And we call that benign because it doesn't cause disease, or likely benign. Now, in the middle, we have the variants of unknown significance or uncertain significance. And these are spelling changes that could cause a problem, but we might not have enough evidence to say it does. We're unsure. And so in prenatal genomic testing in the PREGEN study, we only reported variants of uncertain significance under very strict conditions because they cause a lot of problems, they can raise anxiety, and they might not be the cause of what's going on. So you don't tend to report them in a prenatal context in case people take action on them when there's no evidence to do that. However, we did report some variants of uncertain significance. One was in a parent affected by a condition, and we found a variant of uncertain significance in the gene that caused the condition. And the baby was presenting with the same condition on ultrasound and had the same variant of uncertain significance. And once the baby was born and they got a bit more data on the variant, it was upgraded to likely pathogenic. We also reported variants of uncertain significance and to go back just to some basic genetics. So we've got 2 copies of every gene, one from our mum and one from our dad. And when we talk about conditions that are genetic, you can have dominant conditions where only one gene has a spelling mistake, or you can have recessive conditions where both genes have a spelling mistake. And sometimes what we found a gene where one copy had a spelling mistake and the other copy had a variant of uncertain significance, but the clinical picture of the baby on ultrasound really fitted this gene that we'd found the variants in. So often we do really big rushed meetings where we'd meet with all the bioinformaticians and things, and we try to work out, is this VU the cause of an autosomal recessive condition? And if we felt very strongly it was, we would report it. And that actually led to a life-saving diagnosis in one case, which I'd love to tell you about if you've got the time.
Wow. I think one of the things that is coming through really strongly here is just how complex all of this is and how important it is that you have really expert teams that sit behind this, both from the laboratory perspective, from the clinical genetics perspective, so the medical side of things, and from the genetic counselling perspective.
Fetal medicine as well. And of course, you also work with other specialists. You might want your patients to consult with a neurologist or a cardiologist as well to make a decision on either if we have a diagnosis, what that means for the baby, or if we don't have a diagnosis, what the ultrasound findings might mean. So it's a really wide group of people who are involved in managing cases where differences are found on ultrasound.
So it would be wonderful to hear about the case you just mentioned, if you don't mind sharing, and if it's possible to do so without it being identifying in any way.
It's been published in the New England Journal of Medicine, so it's definitely allowed to be talked about. We do keep the patients private. I had the pleasure of interviewing the parents both times at time point 1 and time point 2, so I feel very connected with this story. So basically, we had a little bub, an unborn bub, and he had a slightly different heart, bell-shaped abdomen and rocker bottom feet. So quite soft markers. And we almost didn't accept them into the study because we thought, is this really bad enough? And we did accept them into the study and we found 3 variants. So the first variant we found was in FLCN, and that caused cardiomyopathy, and it was inherited from one of the parents. That explained the differently shaped heart. Then we found 2 other variants in the Adams T13 gene. One was pathogenic and one was avuse. And Adam's T13 can cause congenital purpura thrombocytopenia. I hope I've said that. It basically causes bleeds where you don't clot and you can bleed out, and it's lethal in the congenital form because during birth, the baby doesn't make enough platelets and it'll get bleeds and unfortunately pass away. So you can see how we really needed to get this one right, because if this baby did have Adam's T13 CCTP, then we would need to start treatment from birth. So the team got together and they found, and this is very roughly sort of paraphrasing because it's very technical and I'm a genetic counsellor, not a lab person, but basically they found that this VU in one copy of the gene had very similar variant described a few years before that did cause a problem in the same area. And it bonded to the same part of the protein that this VU was meant to do that would cause a problem. So after doing a few more studies, they said, yep, we think this is a real finding. We think this is pathogenic or likely pathogenic, and we reported it. When the baby was born, they tested its levels of Adam T13 enzyme and they were 0, and fresh platelets were started under an hour after birth. And the baby already had several bleeds as well. So just during the birthing process, it had several bleeds and platelets were started. And at 16 days post-birth, there was approval from a drug company in America that let us use recombinant Adam's T13 enzyme with the baby. And now he's 2 or 3, I think he might be 3, perfectly normal, perfectly healthy. He does have to have an infusion, I think it's every week, of the Adam's T13 enzyme, but he wouldn't be here with us today if we hadn't picked that up prenatally. And it's not even what we were looking for. It was a completely incidental finding. Didn't explain the rocker bottom feet or the bell-shaped thorax or abdomen. It was absolutely out of the blue. So that was a really incredible situation for the PREGEN team.
Wow, those kind of stories give you goosebumps, don't they? And what about
Certainly
the
gave me.
what about the cardiomyopathy that was identified? Was that already known in the parent, or was that one of the
No,
scenarios where that was identified in a parent, a new finding in a parent?
it was a new finding in the parent, but I think the little boy's Adam T13 findings overshadowed the parent's findings about the cardiomyopathy. I think the parent that it was inherited from was sent to a cardiologist to get a checkup, but it was quite a variable penetrant condition. So it wasn't necessarily life and death for the parent. And during the interview, I really clearly remember mum just being so focused on the fact that we'd found this Adam's T13 pathogenic variants and managed to put treatment in so quickly to avoid a really serious outcome.
Yeah, you can see why that would be the focus for the family. I was thinking about it from the perspective of some of the other cases that you mentioned where a finding was also found in a parent. And I guess that's another thing that often comes up in genetic testing, is that we will find, if we're testing a pregnancy or if we're testing a young child or an older child even, we might find something relevant to the parent, one or both of the parents as well, and their health. How did you find the families responded to getting that information? Were people expecting that they might find out something about their own health? Was it a surprise?
Now,
How did they respond?
this gets a bit difficult because I haven't clinically worked in that situation before. I've only interviewed patients who've been in that situation. So I haven't been on the ground when a patient's been given that kind of result. So I don't know what the immediate reaction is like in clinic. I know that for some parents, it really validated them because they had wondered if something was different about them. Other patients, it caused increased anxiety because of their health and because they were worried that they would develop problems. And I hope, and what should have happened, is that there would have been adequate pre-test counselling saying that this could be an outcome, because really the most essential part of this whole process is the pre-test counselling and consent, which is so incredibly vital, because on the consent forms that a lot of places use now, we do talk about incidental and secondary findings. And if you're doing a trio prenatal genomic test, which means both parents and the baby, this is really important to tell the parents.
Yeah, absolutely. And I think that is one of those things that always needs to be covered off at the beginning so that people are aware they could get more information than they had bargained for. Just before we wrap up, I'd love to talk a bit more about the psychosocial side of it. And I think there have been a couple of points during this conversation where you've really highlighted exactly how valuable genetic counsellors are being involved in this whole process. I guess it would just be, we've talked about the managing uncertainty, and you've talked about, I'll put it in your words, making the experience feel less crap. But which I completely agree with, because it is a really difficult situation and we can't take away some of that. We can't take away some of that emotional impact, but we can hold people's hands through it. And that can help them and empower them to navigate it with a greater degree of confidence. So I guess I'd just love to hear your reflections on that, on your role supporting people through these times. What are the kind of common things that you see? What do you think helps people during this situation? And I guess, anything else, any other pearls of wisdom that you might have?
I'm not sure about pearls of wisdom. I tend to be very patient-led when it comes to offering support. Some people need a lot of support, like they want a weekly check-in and to talk about where they're at, and we can't necessarily provide that ongoing. So in that case, I might talk to them about the genetics component, and if I think they need long-term support, I'll get them in touch with mental health care or psychiatry at the hospital I work at. We have a really great resource in WA that you can get 10 free counselling sessions through. I tell my patients about that. So if they need a lot of support, I do offer more support than normal, but I do remember that we are not long-term psychosocial counsellors. Some people are really much just want to deal with it by themselves. And for them, I might just drop an email every 3 weeks just saying, hi, I'm here if you want to talk. Hope you're doing well. And most people really appreciate that I'm not in their face and I've taken the cue from them. Unless they want to talk and tell me they want to talk, I'm just leaving the ball in their corner. So everyone's really different and has different support needs. And it's up to you as the genetic counsellor to work out what will work for this patient. And that could be as easy as asking the patient, how can I support you through this? Sometimes people don't know what to say, so you can give them the options. Do you want to have a call every couple of weeks? Do you want another follow-up appointment and I can leave you alone until then? What would be the most helpful thing? And I always give them resources as well. So for pregnancy loss, there's things like Red Nose, which has the 24 hours hotline. There's quite a few resources that you can give people that have 24-hour lines so that if you're not available, they can talk to someone if they're in a crisis. And I think that's really important to provide as well.
Amazing. So I guess to sum it all up, what do you think the key points are that people need to know about genomic sequencing in pregnancy? And I guess I'm thinking predominantly for people who might be less familiar with this process. What really matters in terms of going through this process?
I think the most important aspect is good pre-test counselling and consent. So patients know exactly what they're getting into, what the potential outcomes are, what the turnaround time is, what the plan for getting the results is, and what the options are depending on the results. And I think this should be really clear, hopefully a written consent form for the parents to sign, and then you copy it so they can take a copy home so they've got everything documented as well. I think if we do the counselling and then we do this kind of informed consent, then that's pretty much the take-home message about prenatal genomic counselling. Make sure you have a plan, make sure you do really good consent and the patients have a really good understanding.
And everyone going through this process should have access to genetic counselling.
Absolutely. That was a given.
Yeah, exactly. Exactly. Sarah, thank you so much. I think you've shed so much light on prenatal genomic sequencing. I think all the research that's been done is fabulous and sounds like it's had some really important findings and you've captured so much valuable data. So thank you for all your hard work in that space and for just broadening our horizons about this particular topic.
Thanks so much for having me. I do love talking about my work. Yeah, it's been really enjoyable. I will just give a plug for my postdoc, which is called GeneSafe. We're actually looking at doing whole exome sequencing on people with changes on ultrasounds through non-invasive means. And I'm looking for women who are undergoing whole exome or whole genome sequencing due to a change on the ultrasound. and I'm interviewing them about their views towards invasive and non-invasive means of testing. And so hopefully going to recruit for that and see how that goes.
Well, we definitely need to get you back to talk about that when you've got enough participants and data to be able to share. I also just wanted to flag that there's an earlier episode, I think it's episode 3, where I interview Gillian Kennedy, who's a genetic counsellor, also from Western Australia. And she talks about CVS and amniocentesis. So she explains how prenatal diagnostic testing works in terms of the procedures. And given that we've referred to that quite a lot in this episode, if people want to understand more about that, then they can also listen to episode 3. But yeah, it would be great if anyone who's interested in Sarah's research can reach out to her and connect. I'm just thinking about the best way to do that. We might have to put a little study flyer in the show notes or something, Sarah, so that people
Absolutely.
Yeah.
I'm also very available on LinkedIn as well.
Perfect. Okay. Thank you again.
Thanks so much, Alison.
Yes.